sticky, it starts to make it mature, and it takes approximately 5 days. You ovulated on day 14, you're ready for implantation for that fertilized egg to implant on day 19. Okay, what happens? The egg is fertilized on day 14, and within a few hours it divides. And now you've got two cells. There was one, the sperm and the egg got together, right numbers of chromosomes, and you have now one cell. That cell divides. And now you've got two, and then it will divide again, and you'll have 4, 8, 16, 32, 64, 128, 256, 512. It's dividing all the time. Okay? And every time it divides, each individual cell gets a little bit smaller. And you get a little ball of cells. And this little ball of cells, this early embryo, has to make it through the fallopian tube into the uterus. And it has to take 5 days. Because if it gets there in 2 days, the lining of the uterus is not ready for it. You did everything right. Timing was right. Conception was right. Right numbers of chromosomes. Everything was right. But it got to the uterus too soon. The lining of the uterus is not prepared. It dies. It can't implant. The lining of the uterus is not sticky. It's not thick enough. It's not mature enough. And that fertilized egg dies. You don't know. Just, all of those months that you thought nothing was happening, that conception didn't take place, it might very well have taken place. But it's all about timing. Conception sometimes didn't take place, you didn't ovulate at the right time, you missed it, and other times you did, and then that little ball of cells developed so far, and then something was wrong and it self-destructed, and another time maybe it got to where it was supposed to go, but it got there too soon, and problems happen. So it has to arrive at the right time, because the lining of the uterus has to be sticky, it has to be mature, and that's not going to happen until approximately day 19. What if it takes too long? What if that little ball of cells is inside the fallopian tube for too long and it's dividing? Now that fallopian tube is a tube. It's not a big tube. It is really quite thin. It's big enough, certainly, for the sperm to swim this way, and it's big enough for that ball of cells to float this way and make it into the uterus. But it's only so thin. And it can only expand so far. And if that pregnancy takes too long, if that little ball of cells is in the fallopian tube too long, it might get stuck there. And every one of you has heard of someone who had a tubal pregnancy, right? An ectopic pregnancy. An ectopic pregnancy means a pregnancy that's in the wrong place. Usually the wrong place is in the fallopian tube. Okay? Although wrong place could be right in the corner where the fallopian tube comes into the uterus, or it could be on the surface of the ovary. Sometimes we see an ovarian pregnancy, and really, really, really rarely a pregnancy can develop inside the abdomen. Okay? An abdominal pregnancy. Really, really uncommon. Never seen one in my life. I thought that I saw one once when I was a resident. That's a long time ago. But I'm not sure. And since then, I have for sure never seen one. Have I seen ectopic pregnancies? All the time. How often do ectopic pregnancies, tubal pregnancies occur? We think approximately 1 in every 250 pregnancies. So it's relatively common. And we see them all the time, and I will see several over the course of a year. Okay? Several. Sometimes really bad luck, 2 in a day. So sometimes it doesn't go the way it's supposed to. Why do girls end up with ectopic pregnancies? Because the first question that I'm asked, I operate on a girl who has an ectopic pregnancy, and we have to remove a fallopian tube. The first question that she asks is, what did you do? That's reasonable. And the second question is, why did this happen to me? Right? So telling her what I did is easy. Answering why did this happen to me is difficult. And usually the most common cause of an ectopic pregnancy is bad luck. We look inside, we operate, and everything looks okay. Bad luck. It spent too long in the fallopian tube trying to get through. Bad luck. Instead of getting through in 5 days. It was 7 days, and it just got too big, and it got stuck. It just couldn't get through. Sometimes we see signs of infection. At some point in the past, you had a pelvic infection. Infection often causes scarring. Sometimes the fallopian tube gets blocked. Sometimes it just gets kinked. Sometimes the damage is to the lining of the fallopian tube. It's not normal, and instead of the fallopian tube being this big, it's this big. And the sperm can still swim through this way, but that ball of cells coming this way can't get through because of scar tissue. So previous pelvic infection will cause it. Sometimes the fallopian tube has a little outpouching, like a little cul-de-sac. You're driving along the street, and you turn into the street, and it says no exit, right? And somebody has built 15 houses on this little cul-de-sac. You drive in and you drive out. But if you have a little ball of cells that's fertilized and it somehow gets into this little outpouching, it got there by accident. It was supposed to go this way, and it went this way. It got into this little outpouching by accident and by bad luck. And to get out, it has to get out by good luck. What do you think the chances are that it's going to have bad luck and good luck at the same time? I don't think so. Once it gets into that little outpouching and it's still dividing, it's still growing, it's going to get stuck there, right? If you drive into a little cul-de-sac and I tape up all the windows in your car and you have no GPS, you don't know where you are, you don't know what direction you're going, and I spin you around and I say, okay, drive out, chances are you're going to hit a tree, or you're going to hit a lamppost, you're going to hit a fire hydrant, you're going to drive onto somebody's front porch, and you're going to get stuck there, and you're going to run out of gas. And so what you do, you just say, okay, let's see if I have good luck. Let's aim the car in this direction and gun it. And if I get out, that's great. And if I don't, I slam into a post. Right? The chances are, once that little ball of cells gets into the wrong space, it's going to stay there. And now you've got an ectopic pregnancy. And you have a problem. The problem with an ectopic pregnancy is it's in the wrong place and it's growing. Now, a lot of times ectopic pregnancies occur and we don't even know because it just dies there. It develops in the fallopian tube and it dies there. Bad luck, good luck at the same time, right? Got it in the wrong spot. It's in the right place. It's stuck in the fallopian tube, but it doesn't develop. It just dies. It gets reabsorbed. Now, the tube may end up blocked or damaged as a result, but it doesn't rupture. But sometimes you end up in the emergency department with abdominal pain. And if the right diagnosis is made, they do a pregnancy test, they take a proper history, and they examine you, and we find that you've got an ectopic pregnancy, you end up in the operating room to resolve it. Sometimes if it's really early, and we find it by good luck or by ultrasound, and we make a diagnosis if it's very early, sometimes we can treat it with drugs to make the pregnancy stop growing, to kill it at that point, and it reabsorbs. It's complicated. Sometimes it works, sometimes it doesn't work. But a lot of times you end up with surgery. And you end up with surgery because it's too far along for chemical treatment, and sometimes because the tube is ruptured and now you are bleeding, and you're bleeding internally. You can't put your hand on it and stop the bleeding. You need to operate, to have surgery to stop the bleeding, and once a tube is ruptured, a lot of times you end up losing the fallopian tube. And mercifully, you still have one on the other side, which hopefully will be okay. So we've seen lots of girls who have an ectopic pregnancy, and as long as it was for bad luck and the other fallopian tube is okay, you can have a whole family on one fallopian tube. But if you lose a fallopian tube because the tube is damaged and the other one is damaged, you got a problem. And usually we tell girls who have ectopic pregnancies that their chances of this happening again are about 10%, even if the fallopian tube looks normal, because we're not looking at the inside of the fallopian tube and we can't tell if there's been damage to the lining of the fallopian tube. So about a 10% recurrence rate. Fair? So that's how ectopic pregnancies occur. If nothing happens, and everything happens the way it's supposed to, that fertilized ball of cells makes it into the uterus, and it makes it into the uterus at the right time, on day 19. Okay? And at that point, it has to stick on. If it doesn't stick, it's arrived in the right place, it's arrived at the right time, and it doesn't stick, it dies. Never stuck on, it gets washed out, it dies, it never implanted. You didn't know. It's day 19, you haven't got a clue. It hasn't implanted, you don't know, and you get your period when you're supposed to around day 28, 29, day 30. But if it ends up in the right place at the right time and now it sticks on, it implants. Before that time, two things would have prevented implantation. Number one, the lining of the uterus wasn't ready, and number two, that ball of cells wasn't mature enough to grow into the uterus. But now on day 19, it is. And it arrives inside the uterus and it sticks on. And wherever it sticks, that's where the placenta is going to develop. Now, we're mammals. We need a placenta. We can only develop so far without mama. We need mom. A placenta has to develop, and through that placenta, that embryo, that fetus, is going to grow, and it's going to develop into a baby. But we need a placenta. And wherever that placenta develops, that's where it's going to stay. It can't pick up and move. So it's all about real estate. Think about the inside of the uterus as real estate, right? Good real estate and bad real estate. If you buy in the right part of town, it's a good neighborhood, good schools, property value goes up. Good real estate. Bad part of town, schools are terrible, gangs, comes time to sell the house, you can't sell it, or its value has gone down. So there's good real estate and bad real estate inside the uterus, good location and bad location. Where's the best location inside the uterus for your placenta to develop? Where's the best place for it to stick on? And you have three choices. Right down here, right up here, or on either side. A side wall, so front, back, or either side, somewhere on the side wall of the uterus. Where's the best place for the placenta to develop? The best place for the placenta to develop is on a side wall. Okay? That's the best place. The second best place for the placenta to develop is right at the top, and the absolutely worst place for the placenta to develop is right at the bottom. So good location, bad location. And right now, each and every one of you is thinking, where's my placenta? Right? He didn't tell me where my placenta is. Right? He didn't tell me. And I will if there's a problem. So here's the story. You don't need to know where the placenta is. You need to know where it isn't. And as long as it isn't here, you're okay. Because you can't move that placenta anyway. You don't need to know if it's here or here on side wall. It makes no difference. Front wall, back wall, side wall, it makes no difference. All you need to know is that it's not here. Because if that placenta is right at the bottom and it's covering the cervix, you have a placenta previa. And when the time comes for you to go into labor, that baby has to go through the placenta. If it tries to go through the placenta, you will bleed. You will bleed a lot. And if you were in a situation where you couldn't get medical help and nobody knew you had a placenta previa and you went into labor on a placenta previa, chances are you would bleed to death. Baby would die and you would die. And it's his fault, right? He got you pregnant. Agreed? So it's always our fault. You don't need to know exactly where it is, but you need to know where it isn't. And I will tell each and every one of you if your placenta is in the wrong place. Okay? You've all seen me go through the chart. You come in and I'm always writing and I'm always flipping through the papers. And I'm looking at the results of your blood tests. I'm looking to see whether you're Rh positive or Rh negative. I'm looking for how the baby is growing because of the ultrasounds that we've done. And it tells me about the location of the placenta. So let's talk about that just for a second. Okay? If you came to see me early on in the pregnancy, I took a history, did an examination, and in that first examination, it was a little more than each of the others. The first examination took a little bit longer. We talked for a little while. I took a history from you, and then we did a general physical examination. I felt your thyroid. We listened to your chest. We did a breast examination, took your blood pressure, listened to the heart, did an abdominal examination, and then I did an internal examination and a pap smear at that time. And when I examined you, I tried to determine the size of the uterus. Does the size of the uterus fit with her dates? She just told me her last period was 10 weeks ago. Does this uterus feel like a 10-week size uterus? And if it does, the dates are pretty much correct. But if that uterus is 14 weeks in size, well, maybe her dates are wrong. Maybe she's got fibroids. Maybe there's something else going on. Maybe there's more than one baby in there. There are issues. Or if she should be 10 weeks and I find that that uterus is only 6 weeks size, it may be that this is a miscarriage, just hasn't miscarried yet, or the dates are wrong, so we need to sort it out, right? And sometimes you'll come in with some bleeding early on and you get an ultrasound done. We try to sort out whether this is a viable pregnancy or a non-viable pregnancy. Is it a miscarriage? Is it a good pregnancy? And miscarriages are common. Miscarriages occur approximately 15% of the time. 1 in every 7 or 8 pregnancies is a miscarriage. It's extremely common to see miscarriages. It's extremely uncommon to see recurrent miscarriages. 2 in a row? Sure. 3 in a row? Not very common. 4, 5, 6 in a row? Really uncommon. Does it happen? Yes. Does it happen often? No. But we see miscarriages all the time. And they occur because of reasons we talked about. Wrong place in the uterus, it didn't develop properly, wrong chromosomes, something major was wrong. The pregnancy has to be in the right place, right chromosomes, right time. All of that has to happen properly. And miscarriages are going to happen. And everybody knows somebody who had a miscarriage. Well, there are a lot of issues. The anatomy has to be right. And let's just talk about anatomy again for just a second. We talked about the uterus, and we talked about the fallopian tubes and the ovaries. But let's just talk about early development. We develop right side, left side. We don't develop front, back. So right side, left side, if you look at a normal person, they look fairly similar, right side, left side in front, a lot more similar from the other side, right? And here's the split, right down the center, and we join up from right to left, okay? 2 eyes, 2 noses. You can see where the mouth came together, right down the center, 2 lungs, 2 hearts, a right and a left heart that have come together to form 1 heart, 2 kidneys, all the way down, 2 testicles, 2 ovaries, 2 fallopian tubes, and they join in the center. But we start out right, left. And we have to close front and back, right? So our abdominal wall has to close, and everybody has heard about or seen pictures of babies that have a cleft lip or cleft palate where it didn't close. You may not have seen babies that are where their abdominal wall is open, but we've all heard about spina bifida, where the spine hasn't closed. And so everybody has had some ultrasounds. If you come in with a little bit of bleeding early on in the pregnancy, we do an ultrasound to make sure there's a viable pregnancy, that it's developing the way it's supposed to, that it's not an ectopic pregnancy, it's where it's supposed to be inside the uterus. But at around 11, 12 weeks, if you came to me early on, everybody had an ultrasound. And everybody had a whole series of blood tests done at that time. And we do what's called integrated prenatal screening. And we're looking for an abnormality. And the big abnormalities that we're looking for are spina bifida and Down syndrome, right? We want to make sure that the spine is closed. Now that first ultrasound is interesting because the baby is small, right? It needs to be done by about 13 and a half weeks. After that, it's too late for a measurement called a nuchal translucency. So when you had that first ultrasound done, they measure the size of the baby, and they can tell me how far along you are in your pregnancy really quite accurately. And that ultrasound will say you're 12 weeks, 2 days, plus or minus a little bit. It's really quite accurate. And if it's been done properly, it's really very accurate. If there are mistakes in how it's been measured, it can make a big difference really early on because you're measuring something that's very small, and so a small error can be multiplied into a larger percentage error. But if it's done properly, we can date the pregnancy really quite accurately. And they measure the little fold at the back of the baby's neck. It's called a nuchal translucency. And we want to see that it's nice and small. We want a small number. We want it to be thin. Because if the nuchal translucency is high, it's thick, it's an indicator, it's a soft sign that this baby is abnormal and that it might have Down syndrome. So everybody has an ultrasound. Everybody has a series of blood tests at that first visit. And then 4 weeks later, everybody had a second blood test, because the integrated prenatal screening is 2 tests that are done approximately 4 weeks apart. And on the basis of that, they can give me a risk. They can calculate a risk for whether this baby has spina bifida or Down syndrome. And we want the risk to be low. We want you to have a low risk. Well, the reason for this is because we used to, at around age 35, offer amniocentesis to everyone. And amniocentesis is a test where we put a needle into the uterus, we draw off some fluid, and they analyze those cells to see that the numbers of chromosomes are normal. At the same time, they will tell you whether it's a boy or a girl, because we're going to get the numbers, and it's going to say it's 46XX, it's 46XY, or there's going to be some issue. And we used to offer this to everyone after the age of 35 because the risk of an abnormal baby starts to increase substantially after age 35, and really quite substantially after about age 41, 42, and it really goes up high. So that at age 35, the risk might be 1 in 2,500 or 1 in 3,000 or somewhere around there. At age 45, the risk is 1 in 40. So it goes up really quite dramatically. And so this was a very useful test. But the problem was, when we did the blood tests years ago, and we did just one test, and we did it sometime around 16, 17, 18 weeks, and we just did maternal serum screening, that the error rate, the false pickup rate, was about 4%, 3 or 4%. So I would have to make a phone call, right? I would get a call saying the blood test, I'd get a report saying the blood test is abnormal, and then I'd have to make a phone call. And I'd have to call my patient and say, we have a problem with the maternal serum screen. It's abnormal. You have a high risk of perhaps Down syndrome. You need to have an amniocentesis. Getting a phone call from me is never good. You can call me anytime you want. But if I call you, something's wrong. We're either asking for a donation for the hospital or I'm giving you bad news, right? You don't want a phone call from me. And so I would have to say, your maternal serum screen is abnormal, and I can see the tears on the other side of the phone, right? I can feel your heart rate going up. I can see the tears. I can see your face change. I've given you bad news. And I'd have to say, relax. A lot of times when we do the amniocentesis, the result comes back normal, but you're going to be anxious for a while. And a while could be 10 days until I get a phone call, or a little longer until I get a printed report. But the anxiety level was tremendous. Now with the integrated prenatal screening, we have to offer amniocentesis much less often. We still say if you want to have it after age 35, you can, because the risk is there. But with the integrated prenatal screening, the risk of getting errors is now down to about 1 or 2%. So half the number of people have to get anxious. They're still going to get anxious. I'm going to call and say, listen, the integrated prenatal screening is abnormal. You need to have an amniocentesis. And you can always say, no, I don't want to have it. And once in a while, people do. And we just carry on. But if they do have the amniocentesis, then it's done at that point, because the integrated prenatal screening was abnormal. And then we sort out through the amnio whether things are going to go the right way or the wrong way. And then you're going to have another ultrasound. And everybody gets a second ultrasound somewhere around 18, 19, 20 weeks. And at that ultrasound, we can tell different things. With that first ultrasound, we measured the baby, we did a nuchal translucency, and we could tell how many babies there are inside the uterus. And once in a while, a girl would come in and I say, I have good news, and I don't know what the other part is, whether it's bad news or not, but there are 2 in there. And once in a while, not very often, 3. That's a gang. And I think the sooner you know, the better, right? And then we're going to do another ultrasound a little bit later on, sometime around 18, 19, 20 weeks. And at that ultrasound, we're going to get a better look at the baby. They're going to take a really good look at the spine and make sure that it's closed and see as much structure as they can. So they're going to, and sometimes they can tell what the baby is, right? They'll tell you if you ask, and they can see, they'll tell you what the sex of the baby is. And so if you want to know, you know, and if you don't want to know, then it's a surprise. Fair? And you're entitled to ask. I don't tell them, don't tell them. They for sure don't tell me because I'm not interested, right? It's not my issue. I just want a good baby. I don't care if it's a boy or a girl. Actually, I do. I would like them to all be girls, because then I'm looking after me, right? We just need a few guys around, right? As long as there are lots of girls, I'm in business, right? We just need a few guys. Okay. So that second ultrasound is done around 20 weeks. And again, they're going to measure the baby. They're going to measure the size of the baby's head. It's called the biparietal diameter. The distance from one side of the baby's head to the other side. They're going to look at limb length. They'll look at abdominal circumference and chest circumference, various things like that. And again, give me an idea of the dates and make sure that the dates are as correct as they can be. But the farther on you are in the pregnancy, the less accurate the ultrasound is for dating. The more accurate it is for structure, but the less accurate it is for dating. And everybody gets at least, all things being equal, everybody gets at least 2 ultrasounds. Okay? One early on around 12, 13 weeks, and the second ultrasound sometime around 17, 18, 20 weeks. And then later on, you may get another ultrasound, depending on whether we need it or not. So the issues then become, is the baby growing? Am I concerned about the location of the placenta? Is there something that I suspect about an abnormality? Is there something that we saw on the 20-week ultrasound that says, do another ultrasound a little bit later on? If the placenta was low-lying but not a placenta previa, we're going to do another ultrasound to see if it gets pulled up a little bit. The placenta, remember, doesn't move, but as the uterus grows, it gets pulled out of the way. All right? So everybody will get those. And then a little bit later on, if we really need it, if there's bleeding, if there are growth issues, we'll do another ultrasound. And those are more targeted ultrasounds where we're looking specifically maybe at the baby's kidneys, or we're looking at the heart, or we're looking at the placenta, or we may be looking for cord flow. But there are various issues that will say to me, do another ultrasound. And you may have more than one. And there are some people who, for various reasons, might have 4, 5, 6 ultrasounds. Okay? Most people get 2. All right? Well, we were talking just before about the location of the placenta, right? And good real estate and bad real estate. Well, let's just talk about that a little bit more. And we'll fit into that the concept of a right side, left side. When you develop inside your mom and you're a girl, you develop with 2 vaginas, 2 uteruses, each with 1 fallopian tube and 1 ovary. Okay, 2 vaginas. Oh, here we go. In my practice, I have about a half a dozen girls who have 2 vaginas. When I examine them, there's a septum that divides the vaginas. And they're not divided into top and bottom, because we don't develop front to back, we develop side to side. So the septum goes up the middle. And I can see the septum when I do that internal examination on it. And on each side of the septum, I can see a cervix. I need to do 2 pap smears. If I can see that, I know that you have, that as you develop, that part of you stopped developing at that point, and you have 2 uteruses. Each one is smaller than a normal uterus, and each one has a fallopian tube and 1 ovary. Is it possible for a girl to have a baby if she's got that anatomy, 2 uteruses? Absolutely. Absolutely, and I've delivered a number of girls who have that anatomical situation. What happens often is that they deliver early because that uterus can't expand like a normal uterus. And a lot of times girls end up with cesarean sections because the baby ends up lying in a cockeyed position. So it's an issue. Well, that's one situation where you have a complete double setup. And then the next situation is the septum that divides the vagina into 2 disappears, and there's no septum. You have 1 vagina, but there are 2 cervixes, and they're sitting side by side. You still have 2 uteruses. So two cervixes, but they're tight together like this. And the next thing that happens in development is the two cervixes come together, and you have one cervix, but you've got a double uterus. And then that double uterus expands, and you have one uterus. So it starts out here, and it ends up here, and this is a normal uterus, okay, with one fallopian tube attached on each side. And the advantage to this is that it's big enough for a pregnancy to grow, and a baby can lie in a normal position. Now, most babies are born head first, okay? And in fact, at term, the likelihood, if you ask me, what is the likelihood that my baby will be head first at term, and we're going to talk about this shortly, the answer is 95% of the time your baby will be head first. About 4 or 5% of the time it will be head up. I was going to say bum first, but it might not be bum first, it might be feet first. Okay? Could be folded in two, but it might be feet first. So we say it's head up. That's a breech. And a smaller percentage of the time in a girl having a first baby, less than 1% of the time your baby is going to be sideways or oblique. Well, humans can be born this way. If we're lying head up or head down, we have an opportunity to be born. We have to be straight. We can't be born sideways. Okay? Humans can't come out sideways. So what happens when a girl comes in and she's in labor or her membranes have ruptured and we look down and there's a little hand sticking out? Have we seen that situation? Absolutely. A tiny little hand sticking out of the vagina. Well, you don't pull on the hand. That baby's lying sideways and a hand is prolapsed. She's going to go to the operating room and we're going to do a cesarean section, right? Have we seen a three-legged girl come in and there's a leg sticking out? Sure, we're going to talk about that shortly, okay? So when you have an abnormal anatomy, the baby is more likely to be in an abnormal presentation. And it poses a problem for a number of reasons. So if you've got a uterus that's developed like this, okay? It's one uterus, but it's kind of double, right? If you're like this, you're like a cat or a rabbit, okay? Here you are now with a bicornuate uterus. It's got two horns, one on each side. And this baby is going to lie sideways. When it gets to this point where the uterus is sort of heart-shaped, right? It's got a little dimple in the top, right? It's called an arcuate uterus. The baby may lie obliquely. It may lie straight, but it may lie slightly obliquely. That may or may not be a problem. But if the uterus has extended itself like this, the baby more often than not will lie exactly the way it's supposed to. Okay? So this abnormal uterus poses two problems. Number one, the baby can be in a weird position. And number two, the placenta is going to be in a weird position. And the weirdest situation that I've ever seen is in a girl who had this double uterus, and the baby's head developed in one uterus, and the baby's body developed in the other uterus. So the placenta and the body of the baby were in one uterus, and the baby's head was in the other uterus, and let me tell you, that was a complicated cesarean section. Do we see that very often? Mercifully, we do not. It's extremely rare. And it's not something you want to see because you look inside at the time of the cesarean section and you say, what do I do with this? Never been here before, what do I do? And you have to figure it out, okay? When you have a situation where the uterus is in an abnormal shape, the placenta can have a bit of a problem because the placenta takes up room. And somewhere along the way in one of these classes, I'm going to bring a real placenta. Somebody will deliver upstairs, and I'm going to bring the placenta down. We're going to look at it, and you'll see it. You'll see how big it is, how thick it is, and how much space it takes up. And ordinarily, the placenta takes up a lot of space. And when it's inside the uterus and it's full of blood, it's quite thick. It's about that thick. And if that placenta is sitting right at the top of the uterus, because of its thickness, it may push the baby off to a side. And again, if it's lying right at the bottom, again, because of its thickness, it may cause that baby to lie obliquely. So not only is this a problem because of the placenta location, it may be a problem also because of presentation. But when the placenta is on the side wall, front wall, back wall, right? A side wall, the baby can lie straight. And there's no interference at the bottom, there's no interference at the top, and the baby lies pretty straight, Okay? So do you need to know where your placenta is? The answer is, if you've got a placenta previa, absolutely you do. And I'll tell you what's involved and what we do and why it's a risk and how we prepare you for it, and know that you're going to have a cesarean section. And there will be a number of ultrasounds, and we'll have blood prepared for you in the blood bank. All of these things will be issues. Okay? Pregnancy implants in the uterus. It sticks on. And that's where the placenta is going to develop. That's where it's going to stay. It can't say, bad spot, I think I need to move. Can't. That's where it develops. Think of it as real estate. When you sell a house, you just put up a sign and you sell the house and you move everything that's inside the house. Only in Newfoundland do they move the whole house. The rest of Canada, the house stays and you sell the house and you just move what's inside. Okay? The placenta is responsible for feeding the baby. It's responsible for oxygen and carbon dioxide going this way and that, and it's responsible for feeding the baby. So the pregnancy implants. The pregnancy sticks on, and that pregnancy is looking for blood. It's looking for your blood. Because it's going to get food from you, it's going to get oxygen from you, it's going to grow because you're going to supply it with all of those things. And if it implants in the right spot in the uterus, that's great. If there happens to be a fibroid right behind it, or there's some abnormality in the uterus, maybe it's a bad implantation, maybe it just didn't grow in properly, and it could miscarry. But a lot of times there's a little bit of bleeding early on. And this is called implantation bleeding. As the pregnancy is growing, it's trying to implant. And as it grows in, sometimes it hits a blood vessel and it bleeds. If it hits a big blood vessel, it causes a lot of bleeding, it blows the pregnancy right off, and it's a miscarriage. It's not unusual to see a little bit of bleeding early on in pregnancy. When is it going to happen? Well, implantation is going to take place from day 19 on. And let's say by about day 29, 10 days later, the pregnancy is really starting to grow into the uterus and it causes a little bit of bleeding, and that's right around the time of your period. And you're not sure whether you're having your period or you're not having your period. You still don't have any symptoms of pregnancy, and you're having a little bit of bleeding, but it's not as much as I usually have. Am I pregnant? Am I not pregnant? What's going to happen? And I get a phone call, because here you are now, you're at day 35, day 40. You're sort of 5-6 weeks into it, and you have a little bit of bleeding, and you're starting to feel sick, right? My breasts are a little bit sore. I'm starting to feel a little bit sick to my stomach, and I'm bleeding. So what do? We get an ultrasound, and we look to see if we've got a viable pregnancy. And if we've got a pregnancy that looks okay, and there's a little bit of bleeding, then we say, keep your fingers crossed. I don't know what's going to happen. Go park yourself, take it easy. No sex for the next little while, no heavy lifting, and we'll keep our fingers crossed and hope that everything works out, and most of the time it does, and sometimes it doesn't, and the pregnancy self-destructs. And that happens. And everybody's heard about somebody who's had that happen. But if it doesn't, and it sticks on, it implants. That's where the pregnancy is going to develop, right? There's where the placenta is. It's going to start to grow. Baby, you okay there? Baby's going to get oxygen. It's going to get rid of its carbon dioxide, and you're going to feed the baby through the placenta. Well, it starts out pretty small, one cell, and then it starts to grow. It starts to grow. And at about 20 weeks, halfway through the pregnancy, it's right at the level of your belly button, right at the level of your umbilicus. You're halfway through the pregnancy now. Baby may or may not have started to move. It's moving. You just haven't felt it yet. It starts to move by around 12 weeks. It starts to have its hands and its feet twitch a little bit, but it's tiny. You're not going to feel that. But by around 20, 22 weeks, that baby is big enough for you to start to feel it. And it's starting to move around a little bit. And in the early part of the pregnancy, that baby is using your uterus like a swimming pool. It is bouncing off the sides, it's doing cartwheels, it's changing position all the time. It finally starts to settle into position at around 28 weeks. Okay? At around 28 weeks, if we do ultrasounds on everybody, about 60% of babies are head first, and 40% are something else. They're lying sideways or they're upside down. By about 32 weeks, it's about 75% head down. By 36 weeks, we're talking about girls having a first baby, it's around 90%. And by term, right, 40 weeks, 95% of babies are head first, and a much smaller percentage are something else. Babies moving around all the time. The placenta stays in one place, and the two of them are connected. Okay? Remember, placenta and cord and baby are all baby. They all have to come out at the time of the delivery. Okay? Baby is connected to mama by a cord. Well, let's talk about that a little bit because that's pretty important. So, a cord. Here we are. Here you go. You're the placenta. Do not let go, because if you let go, I will die. And I'm the baby. We're attached. Cord. You're feeding me, Mom. Okay? That baby that's inside you is a parasite. I know you don't think of it that way, but what's a parasite? A parasite is something that feeds off you and gives you back nothing. Okay? Just think about it now. It's a parasite. It gives you back nothing. It's a little bit like a brother who left the house at 17 and took off. Disappeared. He's gone off to see the world. He's gone here. He's gone there. And he's basically bumming. And here he is. He's come back to Toronto at 25. Hasn't got a job. Mom and Dad aren't here. They live somewhere else. But you're here, and you're his sister. And you have a place. You have a house. And he has your phone number. He calls you and he says, "Sis, it's me." And you say, "Who's me?" He says, "It's your brother." "Oh, you're back." And he says, "I'm in town. Can I stay with you? I don't have any place to stay." And your husband looks at you and says, "This is not a good idea. I know what's coming. I know what's coming." And you look at him and you say, "It's my brother." And he says, "This is not a good idea." And you say, "It's my brother." And he whispers to you, says, "Ask him how long he's going to be here." And so you ask your brother, you say, "How long are you going to be in town?" And he says, "About a week." And you tell your husband, "A week." And he says, "All right, he can come over." And over he comes with his suitcase, and you put him in a room, probably the baby's room, right? And there he is. 3 months later, he's still in the house. He has no job. You're feeding him. You're feeding him. She's doing his laundry. He's still a bum. What is he? He's a parasite. Agreed? He's feeding off you. What's he giving you back? Nada. And you can't throw him out because it's her brother. You can throw him out. It's time. You're out of here. That little baby that's inside there is feeding off you. Right at this minute, it's giving you back nothing. You're happy. Your baby is growing. Well, what's it giving you? It's giving you backache and cramps, and it hurts, and your body's changing, and we're going to talk about that. And here's this little baby that's attached to you. Well, what are we doing this for? Well, here's the issue. Let me just fix this for just a second. We're attached. Okay? And that baby is moving around in there. It's doing this. I'm not going to do a somersault, but it's twisting itself around, and here's this cord. And it's tangling itself up inside the cord, like this. Does this happen? Sure it does. We all agree that happens, right? And sometimes this happens. There's a big loop, and the baby